Good afternoon, everyone, and welcome to this session titled Recommendations on Ultrasound in Pregnancy, in collaboration with Sidra Medicine for Doha Healthcare Week. My name is Maha El-Akoum, and I am the Head of Content at the World Innovation Summit for Health, commonly known as WISH. Doha Healthcare Week, for those of you who don't know, is a WISH-led initiative taking place from November 8th to November 14th. It features a full program of activities that are organized with our local partners and stakeholders in Qatar. Given the current circumstances and the switch to digital, the activities are now open to a global audience. So there are some silver linings to this pandemic. We are now accessible to everyone around the world. Doha Healthcare Week offers a wide range of activities for all age groups, including webinars, workshops, debates, and training sessions. Additionally, there will be a number of wellness activities and healthy living initiatives taking place outdoors and socially distanced around Qatar. Today's virtual session is led by Dr. Karim Kalache, Chief of Maternal-Fetal Medicine at Sidra, and he will highlight and stress the importance of ultrasounds in pregnancy. I personally delivered my son at Sidra Medicine just 5 months ago and had an ultrasound almost every month as I was diagnosed pretty early on in my pregnancy with gestational diabetes. So I learned pretty quickly that ultrasounds not only allow us a sneak peek into the uterus to see a glimpse of our bundle of joy, they more importantly provide important diagnostic information about a developing baby that can potentially even save lives by identifying issues and possible complications at a very early stage. So they help to reduce health risks not only on the baby, but the mother-to-be as well. It can also help clinicians advise on the different routes for delivery on a case-to-case basis. For instance, with me personally, since the baby was bigger than average because of my gestational diabetes, I was scheduled for an induction in order to reduce my chances for a C-section or a complicated delivery. So we are very lucky to have Dr. Karim Kalache with us today to tell us more about this from a clinical perspective. Prior to assuming his role at Sidra in 2014, he served as a vice chairman and professor of the Department of Obstetrics at the Charite University Hospital in Berlin, Germany. He is a leading expert with an international reputation for clinical excellence in prenatal diagnosis and obstetrics. He works closely with obstetric teams across Qatar to support early and appropriate management of pregnancies where fetal complications are identified. Dr. Karim, again, it's an absolute pleasure to have you, and thank you for participating. I now hand over to you for your presentation.
Thank you, Maha. I hope you can hear me. And yeah, hello and welcome everybody to this webinar. And yeah, I will just start with the presentation to dive into the subject. And before I forget, my special thanks for the invitation and the opportunity to, to participate, and also for all those that were involved in the preparation of this webinar with, in advance to make it as successful as possible. So I will share my slides. And project the presentation. So I hope you can see the title. Okay, so this is a session on recommendation on ultrasound in pregnancy. I personally think one of the best investment a country can do is to promote for their own people is to promote antenatal care and pregnancy and care during pregnancy and around pregnancy, and especially ultrasound in pregnancy. There are always different views on it, but I think it's a very, very important thing, and we will go through some important points. So Maha, I added 2 slides that are very important for me. For those who are attending. One is where I come from. So I was a professor at the Charite University Hospital in Berlin, at one of the institutions that were involved into developing ultrasound in the field of obstetric. And I can, I don't know if I can be proud of it or not, but I was really part of the development from the beginning, from where ultrasound was completely inexistent to ultrasound became a very, very important part of antenatal care. And I came to Sidra in the year 2014. And this is a picture. Most of the people you see on the picture are still at Sidra. Some of them left us for other institutions. But the first years were, you know, we were very busy with planning the services at Sidra and where to put the ultrasound machine, how to deliver the care. And I think now after 2014, you know, almost 6 years, we are really, really ready and fully operational and delivering a really good, excellent care here at Sidra. So these are my discussion points. I will discuss 3 aspects and I will try to be as short as possible so we will have time to, you know, ask some questions at the end, and I hope I will be able to answer. So the first one, why do we do prenatal ultrasound? Why is it done? Why is it so important to be done during pregnancy? So the focus is really on obstetrical ultrasound. The second aspect is how many ultrasound should we do in pregnancy? Because this is a question I receive many times from my patients asking, you know, is it too much or should I do more or shall I go every week? So we'll discuss, you know, the important ultrasounds and that should be done in every pregnancy, and I will explain why. And then also towards the end, you know, talk a little bit about the team at Sidra, who is performing the ultrasound, how we are delivering care, because there are different models around the world, and which model we adopted to do ultrasound at Sidra. Now, why is it important? To make a long story short, in obstetric, we have a very, very particular, how we say, situation where the doctor is dealing with 2 patients. One is the mother and one is the baby. The mother is accessible to the doctor. The doctor can take blood pressure. The doctor can take a blood sample. The doctor can look at the patient. The doctor can see if she's feeling well or not. But the fetus is only accessible with ultrasound, is not accessible from outside with any other mean. When I started my residency, I was given this, I hope you can see it on the screen. I was given this stethoscope, and I remember we could not do a ward round without this wood pinna stethoscope is called, to listen to the heart of the baby, to just see if the baby is alive or not, to make sure that the baby is alive. This was the only way to communicate with the fetus, okay, with the fetus inside the womb. And you can see it is still performed in some countries around the world where ultrasound is not accessible, just to be sure that the fetus is still alive and there is a heartbeat. And then came ultrasound in the late 60s, 70s, and was implemented in the 80s. So ultrasound is very particular because when you perform an ultrasound examination, there is nothing else comparable in medicine apart, you know, when the patient, you know, usually when you do a surgery, the patient is sleeping and is not seeing what the doctor is doing. But with ultrasound, I usually say, so the doctor is looking at the screen, the patient is looking at the screen, and both doctor and patient or pregnant woman are, you know, going through the results as you are doing the examination. It's a very, very particular examination where there is a very strong relationship between the doctor and the patient, and, you know, where you have to build trust from the beginning, because I also say you cannot cheat. I mean, what you see, the patient is seeing it as well, and you have to be very, very professional when you are performing it. There has been a huge technical development over the years, and I was not doing medicine when this was around. So I will show you 4 pictures of a fetal head, of a baby head, how it started and where we are at the moment. So this is the first ultrasound, okay, one of the first ultrasound picture. Basically, the transducer was sending a wave. Then we have the first peak, and then we have a second peak, okay? So the wave was basically hitting one part of the parietal bone, then hitting a second parietal bone. And when you measure the distance from here to here, you have the head measurement. So the head measurement was the first distance that was available in ultrasound, and it was in the 60s. This was followed by the B mode, where in the 70s, where you could see a shape, okay? You can see now a shape of the fetal head. You can measure the head and you can measure all the structure, but you cannot really see what is inside, okay? And then in the early 90s, and this is where I started ultrasound, where I saw it for the first time. So you have now a fetal head and you have some structures inside. So it was the first time in the early 90s where we have these gray scales and we were able to discern fluid from something solid, a bone from tissue, etc. And then in the mid-90s, you remember the computers were coming in, the first computers, the first processor, everything was going so fast that in the mid-90s we had 3D ultrasound. And this is a picture of what we can see today. So this is in 2020. This is a picture of a fetus taken at around 12 weeks. And we are using what we call the studio mode. These are 3 lights that are placed around the fetus. And you can see the umbilical cord over here, the head, the hand, the ear. You can recognize a lot of things already in the first trimester with the technology we have at Sidra. 2-dimensional ultrasound is still the standard, but 3D can be used as well. Now, just a few words about when it was implemented around the world and where we are in Qatar and how we, what is the program, the current program in Qatar to compare ourselves with other countries. So ultrasound was introduced. I'm going to talk for Europe because I think it started in Europe, then went to the United States pretty late, but Europe was like a pioneer in ultrasound. I cannot tell you why, but maybe the technology between the 2 war wars, and so it was already a big thing in the early 80s. And you can see in Germany, in 1980, there was 2 ultrasound that were offered to pregnant women, and they were offered at around 18 weeks, and one was offered later at around 30 weeks, okay? And I will talk about it in a moment. In Norway, which followed then the German model in 86, but with only 1 ultrasound that was offered at mid-pregnancy, because they said the second one is not important. And Switzerland followed very, very late. This is by the, the country's guideline, followed very late. In 96, they introduced ultrasound. 96 is pretty late. And they introduced 2 ultrasound, one very early in pregnancy and the other one like at mid-pregnancy, but no ultrasound later in pregnancy. So there were, in the 80s and the 90s, there were many, many studies trying to understand how many ultrasound are necessary to improve the outcome of a pregnancy. So is it 1? Is it 2? Is it 3? Is it in the middle or towards the end, or better to do it at the beginning? And I think the current international standard, and this is very important for our population in Qatar, the current international standard is to perform 3 ultrasounds, 3. 1 at the beginning of pregnancy around 10 weeks, and I will explain in a moment what we are looking for. The other one at mid-pregnancy at around 20 weeks, and the last one towards the end. And this is usually reimbursed by insurance company. So this model of 3 ultrasound was introduced in Germany in 95 and is still the model in place. You can do more, you can do less, but this is what is suggested by most of the bodies internationally. And this is also what is done in the United States. An early one, a one at 20 weeks, and another one at around 30 weeks. So I will start with what I think is the most important one. And then I will go to another less important, and then I will go to the least important one. So I'm, Maha, already answering some of your questions. Maybe we'll see towards the end. So, but for me, the most important ultrasound is the one performed in the second trimester at around 18 to 22 weeks, translated into month at around 5 months. Shar Khamsa is the most important, Shar al-Khamis is the most important ultrasound, okay? 18 to 22 weeks or 24 weeks. Why? First, most of the babies will be healthy, but there are some conditions, some disease of the fetus, okay, that we can see on ultrasound that will save the life of the baby. Many of them, but I will just describe into a bit more details one of them. It is the transposition of the great arteries, okay? And I remember it was one of the first anomaly we diagnosed at Sidra. It's quite rare, but it can happen, especially in a family where there were heart diseases in a family. And so we have the left chamber of the heart, and from the left chamber of the heart, the vessel that leave the left chamber of the heart should be the aortic arch and the aorta, and should go to the fetal body. And then we have the right chamber of the heart, and the right chamber of the heart should give the pulmonary artery that is going to go to the lungs. But in this complication, in this malformation, or in this disease, the vessels are transposed. So we have the aorta that is leaving the heart from the right, and the pulmonary artery that is leaving the heart from the left. So it's basically as if somebody took the two vessels and just switched them in the wrong chamber. So when these babies are born, they get sick very rapidly, and they don't have enough oxygen that will go to the brain, and they usually end up, they survive, but they usually end up with very severe handicaps. A simple prenatal ultrasound can diagnose this anomaly and can allow delivery in a center like Sidra, okay, where we have the cardiac surgeon and the very expensive cardiac team, and where the baby can be saved from, you know, its brain development, and sometimes they die if they are born remote. So this is a simple ultrasound that can save the baby when it is done in the right way. This is number one. This is from the baby. Now in Qatar, we have you know, something that is a bit different than in other countries. We have many, just looking at the watch, yeah. We have many cesarean sections, and many cesarean sections can cause that the placenta is attached to the lower part of the uterus. And when it's attached to the lower part of the uterus, we can perform a cesarean section, is not a problem, but sometimes the placenta is also attached to the scar. And if you don't know it and you do a cesarean section, we call it placenta accreta. And if you don't know it and you just perform a cesarean section, let's say in a hospital like, I will not say a name, but in a hospital where you are not ready for it, it's very simple, the mother can die. So you have to be prepared for it. And this is why I think the second trimester ultrasound is very important to exclude major complication that can happen in every pregnancy. Fortunately, they are rare, but this is why is it important? Well, it is important. Now I will move on to the first trimester ultrasound. Important, but not as important as the first one I was just talking about. This is an ultrasound that is performed around 12 weeks, a Charite, okay, third month. It's the beginning of pregnancy, and most women just want to know, am I having one baby or two babies? Is everything okay? Is the baby in my uterus? And is it a good start? So this ultrasound, I think, is a very difficult one to perform because the baby is still very, very small, smaller than a match here. You can see on the picture, the comparison. It is very important ultrasound because we are going to measure the fetus. You see, we are measuring from the bottom to the head, and we are going to be super precise and determine the gestational age. This is the first time we are going to be sure about which gestational age exactly we are. And then we are going to see if it's one baby or two babies. I like this picture because I took it many, many years ago. With 3D ultrasound, both babies were in one sack, and you always had the impression they were hugging each other. But especially, this is a very important picture as well, because if it is a twin pregnancy, and if they are in one sack or they are sharing one placenta, they need really special care and an ultrasound every 2 weeks. I am not going to go into more details, but this is an important thing to see early. And then we are going also to try to exclude major chromosomal abnormalities. For example, if the nuchal translucency, this part of the neck of the fetus, which is always there, it's very thick. If it's very thick, it can be a sign that this baby is very sick. We can diagnose it early and react on it depending on the parent's choice. So you can see very severe anomalies very early, but our aim is always to exclude and to be sure that everything is starting in the right way. Now, it's a very difficult ultrasound to perform because with every week and every day, you know, when you do an ultrasound of, let's say, an adult shoulder, it's the same picture always. But in the fetus, at 8 weeks, at 10 weeks, as you can see on the picture, at 11 weeks and at 12 weeks is a completely different picture of the head. Every day gives you a different picture. And this is why you need a lot of years of training, you know, to be sure what is normal and what is abnormal. So this is my message to the community. Usually, if you are told outside, you know, in another institution, maybe in a private practice or so, that something is wrong or so, don't panic, because an expert can usually make sure that everything is okay, because these early ultrasounds are really, really difficult to perform. Now, they can be done transabdominally, they can be done transvaginally, but usually we do them transabdominally because the machines are so good nowadays that we don't need an internal scan and there is no harm for the baby. Now, sometimes patients ask for it. Can you see the gender? Because I want to know if it's a boy or a girl. I want to know it as early as possible and to buy, you know, some nice things for my future baby. We can, but again, in very experienced head. So this is the lower part of the body of a fetus at 11, 12 weeks for Charite. And you can see there is something pointing up here. So this is probably a boy. And this one is a same picture of the lower part, but the tubercle that is not pointing up but pointing down is going to be probably a girl. So we are pretty good at saying is the boy or a girl. Anyway, there are always two possibilities. Either it's a boy or a girl, and sometimes we are wrong, but in, let's say, above 90% of the cases, we get it right. We are trained to do it. Is not a purpose to do it, but we are trained to do it because there are some diseases that are more linked to girls and to boys, and we need to, you know, be able to do it early in pregnancy. So I will finish with the last examination. This is a Shahr Saba, you know, Shahr Taman and Tesa is the last one. This is 7 months, okay? And this is an important one just to make sure that the baby is growing well. if you go outside in the community, you know that diabetes is a big problem. We have a lot of women and men in the community that are overweight, that are obese, they have diabetes. The same can affect a baby. So the last one is to basically what we can do with our hands, and we can measure with the centimeter band, but we are not very precise. So most of the obstetrician will just try to palpate, but you need an ultrasound to be as precise as possible to say this baby is too small and needs an early delivery, or this baby is too big, is really big and is at danger and should not stay anymore in the womb and should be delivered, and the best way to deliver is a cesarean section. This is the last ultrasound. It's more about growth and making, because the other thing were done earlier. The last one is about, is the growth normal? Is everything normal? And or do we need to intervene because the baby is too small or the baby is too big? Now, this is how it is done briefly. So we do it by measuring different parts of the baby. We can obviously not weigh the baby. This can only be done after delivery, but we are going to measure different parts. And I show you one picture. This is a abdominal circumference of the baby. Okay. This is the area, of the abdomen. And we can see here the spine, and we can see the stomach, and we can see the umbilical vein. And again, this is the most difficult measurement that is obtained in the baby, because you are measuring a structure where the baby can flex, etc. So if your doctor tells you your baby is too small or your baby is too big, don't panic. Usually a second opinion is necessary, and you can always come at Sidra or any other institution and then check again if it's really true, because sometimes physicians have the impression that the baby is too small and then they deliver too early, and it was not necessary at all, okay? Or it's too big, you do a cesarean section and the baby's size was normal. So this is also, I think, where an expert opinion is usually helpful. So now I will finish with 3 statements. The vast majority of babies are healthy. The vast majority are healthy, and ultrasound is needed in just a small part, but we don't know which one is healthy, and this is why it is performed in every pregnancy. The second one is obstetric ultrasound. We know it from many, many studies, can improve the outcome of pregnancy when it is done correctly, okay? And the third statement, the very important one, is ultrasound doesn't harm the fetus at all, nothing. Of course, you don't have to do it every day, but one ultrasound every 2-3 weeks is absolutely fine. This is our setting at Sidra. We have, the latest equipment, and we are really glad, and very proud about it. That is linked to a special software. We can do all the measurements. We can monitor babies. We are sure about the growth. This is our team. So we work with sonographer. It's an amazing team. They are, with an amazing training and with a big, how can I say it? For me, this Corona pandemic didn't change anything. I feel as if I am on holiday every day with this team. I feel happy as if I am traveling, because they are really, experienced, nice with the patient, and I enjoy it every day. So we have maternal-fetal medicine specialists from the US, from Europe, that will, from the region, that will supervise this scan. So we always work, so the sonographer do the ultrasound and the doctor will double check, or sometimes it's the doctor that will perform the ultrasound. We have the latest technology, as I showed you. Sometimes we have to ask our colleagues from radiology to help us with an MRI. And of course, what is unique at Sidra, I think unique, not really, but for a big hospital in the region, is that the parents and dad can attend the ultrasound, and almost never see a woman that comes to the ultrasound without her partner and they enjoy it, because most of the time everything is okay and the ultrasound is completely normal. Now, this is where you can find us. I don't know, Maha, were you here in 2017?
Yes.
Okay, so this is the big cake that was exposed in the entrance hall for Sidra anniversary, the first year of OPC operation. And so the OPC is here and we are in the 4th floor, okay? And this is where you can find us. And of course you have to take an appointment, but for any emergency during the day, you can always come to us and we will try to help you and to fit you in. And this is, I will leave our numbers. I hope the screen can still be seen. Yeah, this is our numbers. OPC 4th floor, we work from 7 in the morning to 3 in the afternoon and longer if necessary. And I think this is the phone number of the, how we say, receptionist that will give the appointment. But again, if there is something, you can always come as walk in and we will be happy to help you. Thank you very much for listening, and I hope it was useful. Thank you.
Thank you, Dr. Karim. That was very interesting, and I saw a few very familiar faces on your presentation. Some of the sonographers you took photos of were my sonographers. That brought back really nice memories. Especially interesting to me also was the evolution of the ultrasound and how the technology has changed over the years. It's something to see. I want to please remind the audience that they can submit their questions through the Q&A option on the chat on the bottom of your screen. So please, I'll wait for those to come in. In the meantime, I'm going to ask Dr. Karim some of my questions. Dr. Karim, what are the most common factors for adverse pregnancy outcomes and how is the fetus affected?
So I would say, depending where you are, in which region of the world you are, there are different factors. I will say for Qatar, I think diabetes in pregnancy is an important one. Higher rate of cesarean section, as I said, can affect pregnancy, of course, 4, 5, 6 cesarean sections, which we see from time to time. And yeah, these are really the two main factors where I can say it can affect pregnancy. And of course, some families, they have genetic disease that will be inherited to the baby, but this is very, very rare. So it's mainly in the region diabetes and multiple pregnancies with cesarean section. And another one also, I think, when you do an IVF or reproduction technique, you need also special care to make sure that everything is okay, because you are going frequently to end up with a multiple pregnancy and then you need special care. Mm-hmm. For the next answer, I will be short. Don't worry, Maha.
No, that's great. So how common is gestational diabetes in Qatar? You said it was very common. Do we have like a statistic on that? And how can you identify the effects of diabetes on the fetus through ultrasound? So what's the effect of the mother having gestational diabetes on the fetus?
Okay, I don't have the exact figures, because we have colleagues at Sidra, they run a diabetic clinic and they're much more specialized, Dr. Shola, Dr. Ibrahim, and the same they know, they have a special interest in diabetes. But I can tell you, my impression is 20% of pregnancy is quite frequent, if it's not 25%. And diabetes will cause, the same disturbed glycemic control in the mother may cause harm to the baby, because the baby will be bigger. Sometimes they get very big. Sometimes they have severe complication late in pregnancy. Sometimes they have cardiac defects. Sometimes they have other anomalies, because poor glycemic control is, how do you say, poison for the fetus. So this is why it's important to know it from the beginning, to have a good glycemic control if you want to do something, you know, if you want to be sure about the good health of your fetus.
Yeah. Thank you, Dr. Karim. We've also received a question from the audience. Can ultrasound impact the eyesight of a baby?
The eyesight?
The eyesight of the baby, yes.
Yeah. No. I want to say here, okay, ultrasound do not cause harm. Talking about the eyes of the baby, in the region, not only in Qatar, but in the Middle East, there are some diseases that are more frequent here than in some other parts of the world. And for example, there is one disease that is called microphthalmia, and I think it's very important to use ultrasound and to do ultrasound just to exclude this anomaly. I've seen it a lot here in Qatar, and to make sure that the eyes are normal. But it doesn't affect any, you know, it has no relationship with the eyesight of the baby.
That's good to hear. And are there any anomalies that exist that actually can't be detected by ultrasounds that can sort of surprise the mother or the parents after birth?
Sure. I think there are certain brain anomalies, I would say, okay. They are at, you know, they are so deep in the brain, and it's about more function, the function of the organs that cannot be detected by ultrasound. An ultrasound is not a guarantee for life. We usually say we have excluded the major thing, but some small thing can still be there. Sometimes the operator is not experienced enough to exclude everything. It can happen. For example, I'm just thinking about something that cannot be excluded by ultrasound. I would say, you know, it's almost everything, but there are some, for example, a cleft palate. For example, a cleft palate, only isolated inside, cannot be seen by ultrasound, okay? A cleft lip, yes, but a cleft palate is not possible. Even with special technique, you will just miss it, but it's not that important. The important ones can be seen with ultrasound.
Okay. And just how early can ultrasounds detect the different abnormalities in fetal structure? So even at the first ultrasound, you can detect these abnormalities? Yeah.
There are very few severe abnormalities that you can be sure of early. Okay, at 3 months, there are very few where you are sure. You can see a lot, we can see a lot, but I usually keep this examination as simple as possible because you don't want to scare the mother. You don't want to tell her, look, I've seen something, but I'm not sure about it. And so usually it's kept as simple as possible, but the majority of anomalies can be excluded later in pregnancy, okay? The beginning is just the size of the baby, 1 or 2, and the major ones. But of course, I can already see a cardiac defect at 10 weeks, you know, very beginning, but usually I cannot take action on it. I have to wait later to be 100% sure. I don't know if it's too confusing. You know, at the beginning, you cannot react on it. You have to wait later. So at the end of the day, why not do it later? And that's it.
Yes, it can cause real anxiety, I think, for the mother and parents.
That's it. Yeah. So if I may something, the beginning is good. If you had a baby that was born with the malformation, okay, which can happen. Let's say you have a baby with a cardiac defect. It's useful to go to the doctor at the beginning to exclude it and to be reassured, okay? Because normal, we are very good at it. But if something is abnormal, we still, you know, we still have to look at it later.
In relation to this, we've received actually another question from the audience that says, do you recommend to always have a second opinion at every step? So in case we hear bad news, do you recommend a second opinion?
So, you know, I always recommend a second opinion. not the second opinion to me or so, yeah. It's if I see something, okay, if I see something, the parents will look at me and they will tell me, you know, like we are shocked and we are, so I tell them, look, there are some other colleagues, they can help you, go and see them, okay? They will usually be in agreement with me, or I will be in agreement with the other, or maybe we disagree, but it's always good and not you know, not, how we say it, not something wrong to have a second opinion in medicine. It's all right. There is no urgency. I usually do it when I go to, I don't do it every time, you know, when you trust your doctor, that's it. But these are shocking news where a second opinion can help sometimes. If it's just something benign, it doesn't matter. So,
yeah. While we're on the subject of diagnosis, I wanted to ask, what's a fetal MRI and what's it used for?
Okay, so MRI, thank you for the question. So MRI is another imaging modality that is performed by our colleagues here in radiology. And it's like a complement to ultrasound. And I have to say, the person that does the MRI here at Sidra and his team, Ashley Robinson and his team, are the world expert. I receive sometimes questions from Germany, from the UK, asking me about to read CDs by, you know, findings by Ashley Robinson here at Sidra. And we have a high quality MRI. We don't need them all the time, but when we are unsure about something and we need really, you know, to be more precise, we will use the MRI, okay? And so it will be done like the ultrasound. Is a bit different kind of examination. It doesn't harm the fetus. It takes about half an hour. So it's the one where you have to go into the tube and then some pictures are taken from the baby. I think in Arabic is magnetisiyah, but everybody knows it. So, and the good thing is, when I was before in Germany, I was not using it a lot because the operator was not very expensive. While at Sidra, we have really a good team. So it's in very particular situation, very helpful.
Yes, it's great to hear that we have the expertise of the world at our fingertips here in Doha. Another question from the audience: when is the best time to do an ultrasound to determine the multiple pregnancy?
Multiple pregnancy from the very, very beginning. You see 1, 2, or 3, okay? The only thing is, let's say if you do it at the beginning, it was shahr thalith, no? When I was talking about it, or even earlier, you can see it very from the beginning. But sometimes where one pregnancy will go on and the other one will just stop. And this is why seeing it at the beginning is not a guarantee that it will be twins or triplets. On the other part, seeing it at the beginning is very important because we are going to know if it's 1 placenta or 2 placenta. This will change the whole way we are going to look at the pregnancy. But twins is very early.
Great. Another question is comes from an anonymous attendee. I have noticed some clinic provide the ultrasound service as a 3D video, and this is usually done just to capture the moment in color. Is it safe? And if yes, how many times can the baby go through this 3D scan?
Okay. So we do it as well at the end of an examination when everything is okay. So we will not spend, you know, half an hour, 1 hour doing it, but when everything is normal and everything is good and patients are happy, so we will provide them some 3D pictures. It's exactly the same as ultrasound. It's just the volume that is taken, has no more power, no more energy. It's exactly the same. It's a different way to render the picture, but it's ultrasound basically. We usually use the same transducer. We don't change even, and it's just a switch of a button and then you see the 3D image.
Yeah, that's great. And what's the difference between 3D and 4D? You have 4D also at Sidra, right?
Yes, we have 3D and 4D. So 3D is a static image of the baby. Okay, imagine you are taking a picture of me. So it's a picture, nothing is moving. 4D is, imagine you are taking all the time a picture at, let's say, 10 frames per second. 1, 2, 3. So if I do this is a 4D. Basically, is a moving 3D. For marketing, they called it 4D, but it's not 4 dimension. The 4th dimension is the time, is the movement.
Okay, that's great.
It's the same technology.
Yes. On average, how many ultrasounds do take place at Sidra a day? Just out of curiosity.
Yes. So we have some days that are more busy. We have some days that are less busy, but we have some patients that come only here for the ultrasound. Some other patients, they come here and they do the ultrasound and then they will ultimately deliver at Sidra, have their babies at Sidra. We have some patients that come here because the baby has a problem and they need to come to Sidra. I would say we do between 30 and 50 a day, but we have not only one doctor, we have the sonographer team that you saw, we have 1 or 2 physicians that are supervising this ultrasound, but this is the number we do every day at Sidra during the week. Yeah.
For the sonographers who carry out the screenings, what types of professional trainings do they go through? What are their certifications? What do they study?
So I think, I don't know exactly the curriculum because we have sonographer from, let me think. We have United States of America, Australia, South Africa, UK. So they come from different regions of the world, but I think they have a curricula that goes over 4 years. And then they usually join a specialized center, and they are very specialized in obstetric ultrasound. They have a lot of experience. When something is abnormal, which happen very rarely, but when something is abnormal, they usually recognize it, but then they need the help of a physician or of a specialist in fetal medicine to, to guide and to say, what is exactly abnormal. But they are very good at making sure that everything is normal.
Perfect.
And we work hand in hand and we share everything. So they are really almost like our eyes, if you want. So.
Yeah. And since we're living in this era, I feel like I have to ask, how has COVID-19 changed the way you operate? And have routine ultrasounds been postponed or canceled during this pandemic?
Yeah, it's a good question. I think at the beginning, if you remember in March, April, when everything was new, so there were many societies and we are part of the boards. And so we try to, because ultrasound is an examination that goes over 20 minutes, maybe sometimes 40 minutes, and you are in very close proximity to the patients. It's just 20 centimeter. The patient is breathing, you are breathing. It's a long exposure, okay? And we wanted to protect ourselves and to protect the patients, of course. So at the beginning, we were not allowing the partner to come. We were not allowing the family to come. We're keeping the ultrasound examination as short as possible. We didn't cancel any appointments because I think every ultrasound is important. You cannot just say we don't do it, and there is no other way to do it. But it was more about the experience. So it was a bit shorter without the partner and with face shield and all the gears. And so now, we have the app, we have ihtiraz, etc. So we are a bit more relaxed, but we are still, wearing a mask and so, and taking our precautions. But partners can come now and even kids. And so we are not allowing more than 3-4 persons in the room, this type of measures. So, yeah. But we are easing them as we go.
Okay, that's good to hear. Dr. Karim, you mentioned there are 3 routine ultrasounds throughout the pregnancy, but in the case of mothers who have high-risk pregnancies and they are diagnosed with hypertension or gestational diabetes, how often do you do an ultrasound for these patients?
Yes. So normally, as you say, 3 ultrasounds, but let's say at the last ultrasound, you find out the one that is done shahr saba, the 7th month, you find out that the baby is too small, okay? And you are not sure, is it the placenta? Is it nutrition? Does the baby has enough nutrition? Sometimes an ultrasound every 2-3 days is necessary. Sometimes you have to admit the patient and do it every 2-3 days to find the right moment to deliver in time and in a safe way. So depending on this condition of the baby and the condition of the mother, it's either 3 when everything is normal, 3 to 4, or many more if it's necessary. Now, the insurance company may say, I see it frequently here, doctor, why are you doing so many ultrasounds? You know, we are not going to pay for them. And then we can write to the insurance company, we can call them, because the person sitting there is, you know, just is not always a specialist in the field. He has just the direction to say only 3. And then they usually say, oh, we understand, baby is in danger, mother needs more ultrasound, it's fine, we are going to pay for it, okay? And this is usually the way it is done.
Perfect. Dr. Karim, do you have any last words, any advice or to patients, possible patients that could be watching, any closing remarks or comments?
Yeah, I was not expecting this question, but thank you for asking it. Yeah. No, I would say, you know, I mean, we like to do ultrasound. Most of the ultrasounds are normal. Is really a nice experience. Is really about making sure that everything is normal. We are against doing it all the time, because when there is no benefit, it's not good to do it. I think we are, you know, fortunate to be given the opportunity to do it. We are not the only one in Sidra that do it. You know, there are many other private centers. There is Hamad Hospital, where I personally work as well, and we cooperate together and we work hand in hand. So I think, you know, the country, it's really at the top level, I have to say, and nothing to you know, to say maybe if I don't go to London or to Paris, I'm missing something. And they can have the best care here in Qatar. And yeah, and I think the Qatar people have to thank their leader to have, you know, promoted it over the years in this way. This is my last word. Yeah.
Definitely, I agree. Thank you so much, Dr. Karim, for your time. I learned a lot and I really enjoyed it, and I'm sure the audience did too. To our audience, thank you so much also for joining us and for submitting your questions. We hope that you'll continue to take part in our Doha Healthcare Week activities. There's a list on our website, which you can access on www.wish.org.qa. Also, if you're interested, please don't forget to register to attend our summit, which is also taking place virtually from the 15th to the 19th of November. Thank you, everyone. Have a great day, and thanks again for joining.
Thank you.
Thank you.